because it made me realize how simple my field is, and yet I can't figure out my field of tendons and nerves. So then it makes me think that the more complex things, we also don't know for sure what we're doing. It's really, there's so many variables about figuring out something like that. It's difficult. I may not get through this talk because I probably made it too long, so if I... oh, here's my clock. I'll run on that. Okay. So the topic I was given, I had to spend a long time thinking about it because it's tendon and nerve repairs I know a lot about, and I made my early career in peripheral nerve research, actually. I was a biochemist by training with a master's degree, then ended up in neurophysiology and ended up in transplants, so you figure that. But the concept of how, when, where, and by whom is interesting. Now, how is pretty straightforward. When is exceedingly important, and if you don't know that, you're going to get sued. Where, I didn't understand. I didn't know if it meant at home, the ER. So I'm going to interpret it in a little different way, which was anatomical. Where anatomically do boundaries exist? And then by whom is political. But I'll give you my opinion on that also. So let's start with tendon repair. One of the most important concepts to really understand in order to kind of sort out how and when, and it is the where, is the concept of zones of repair for tendons. Now, for years, there's been a definition of 5 zones. And the initial concept was that you could repair tendons pretty well in these zones from the palm to the wrist and in the forearm. But this was a very bad zone to work in, and it didn't work well if you tried to repair there. So universally in the 40s and the 50s, it was recommended that tendons divided in the zone 2 and 1, and even in the palm sometimes, should not be repaired. What you were supposed to do is go get a tendon graft and fix it with a tendon graft in this difficult zone in that region. And it was given a name. It was called no man's land. And in no man's land, you were supposed to use the tendon graft. And you were supposed to weave this tendon graft. So if you cut your tendon here, then what you're supposed to do is pull it out, fix it down here with a graft, and then bring the graft all the way through this out to this point. These are the pulley systems, which are a complex segment, and you just, the reason this developed is you just can't go plowing through these. Initially, back in the 30s, when people didn't understand all the biomechanics, they just cut through the pulleys, repair the tendon, that was it, and nothing worked. So one way of respecting the pulleys was to try to put a tendon graft through it. Now, Sterling Bennell, and I'm sure all fields have individuals like this. Sterling Bennell was the one who defined the problem of why you needed to use a tendon graft to solve it. That cutting the pulleys and repairing the tendon wouldn't work. And he is the father of hand surgery in the United States. He was involved both with the military during World War II, lived in San Francisco, started the Hand Society, so on and so forth. So it was dogma that that's the way you needed to do it. Now, Harold Kleinert was the founding partner of the group that I was in Louisville. And in 1954, he left the University of Louisville to focus on hand surgery, and there was no such thing as hand surgery, and those general surgeons who wanted to do hand surgery were considered loony-toony. And one of the first things he did was challenge the concept of primary repair in no man's land. And he came in direct conflict with the Hand Society. It's kind of interesting, that group had a history of doing these things over the years. And eventually came to change the whole concept that you could repair a tendon in no man's land. So, after the 1970s, after it became clear that with proper technique, you could open up the flexor tendon sheath, take the two ends of the tendon and repair it, then the focus on tendon repair changed to strengthening the suture, sometimes increasing the number of sutures you put in, okay? Using a suture on the outside called the epitendinous suture. And one of the most important things was completely changing postoperative rehabilitation. Prior to that, in the 30s, they repaired your tendon, cut all the pulleys, repaired your tendon, put you in a splint for 4 weeks, said go use your hand, see how it works. And what Harold Kleiner was able to show, and actually Harold Kleiner just celebrated just a few weeks ago his 91st birthday. There was a big party in Louisville for him. He put a rubber band, imagine this if you could patent it, it was used ubiquitously everywhere. He put a rubber band and a splint on, and the patients would be passively pulled into flexion and actively into extension. Now, if at this point this lecture is not interesting to you, then you know you shouldn't be doing tendon repair. Because if this isn't second nature to you, you shouldn't be in zone 1, 2, or 3, and maybe even 4. Now, jumping ahead to whom should be doing it, I don't have any dog in the fight. And as a trauma surgeon taking care of extremity trauma and vascular problems, if you know how to do it, you should do it. But be honest with yourself. If you don't kind of understand the trends, and particularly if you don't want to follow the patient, don't. Now, we get in this dilemma all the time because hand surgeons, unfortunately, on the whole, are lazy and don't want to come in the middle of the night. Trauma surgeons are a breed that work all night, and that causes a conflict. So it gets to the issue of what you do if you've got a cut tendon and you don't know whether you should repair it immediately or not, or leave it. When in doubt, don't cut it out, okay? Just leave it. That's not ideal for the patient. That's not the way it should work. Where I came from in Louisville, we slept in the hospital just like the trauma surgeons do at University of Arizona in Tucson. Now, we had the volume of work for it, but we didn't go home. And we took care of as much as we could acutely. With changing economics, we started doing less acutely because it was costing us so much money. We actually owned our own anesthesia at one point, so we still stayed in the hospital, but we would put things off to the morning. So I'll get to the timing of this too. But these issues here, the main thing I want to say, and I'm going to relate it back to the last lecture, since the 1970s, there's been hundreds of articles published on these things. Which postoperative technique should be used? Should we use different types of repairs? Suture characteristics. What's the ideal suture? Easy to place. Smooth. Resist gap formation. And then should it have high tensile strength, inextensible, absorbable, easy to use? Doesn't exist. All the ideal things don't exist. Now, I want you to all get this down because here are all the different types of suture methodologies that can be used to repair a tendon. And when you see this plethora of options, you realize that no one's really figured out what to do. And these are all the different ways you can put the epitendinous suture around the outside. So if you have training in hand surgery and you want to do surgery in zones 1 through 3, I would try to keep it simple. Use a simple Kessler suture, which I'll show you in a second, where you're just doing a kind of a box figure. And be able to practice it and understand how to get between the windows. We actually open up and try to keep most of the pulleys, not all of them, A1 we won't, but keep them intact and work between them. So we'll put a suture in the tendon here and then pull it through and put a suture at the other end to bring the tendons together. If you're not comfortable with that, you shouldn't be doing it. This is an important issue, though, because here's where the intersection of the hand surgeon and the trauma surgeon sometimes get crossed. You can't leave the tendon unrepaired, send the patient home, and then have them wander in my office a month later. That just won't work. The amount of time that you have is somewhere between 24 hours and 2 weeks, and in reality, we don't know. There are no good studies that actually demonstrate when this should be done. So now we get down to the issue of standard of care, because remember, standard of care is not always associated with logic. You know, there's a lot of times things like fetal monitors are an example where there hasn't been great evidence that it changes things. But if you don't use a fetal monitor, you certainly can be sued. Just ask John Edwards. So I would say you have up to 2 weeks. If I was asked as an expert to testify against you for sending a patient at a month, I would tell the truth, and I would say there's no evidence that doing it at a month or 2 weeks makes a difference. There is evidence that if you cut a tendon, disrupt the tendon, and leave it for 6 weeks unrepaired in the palm, that you can't bring it out to its original length. But that's not the same question about repairing a tendon that's been cut. So I think you have a window of opportunity there, but I would meet that window of opportunity. I have no idea how many strands is the proper amount of strands if you're going to do repair. I'm not really sure that more is better. There have been all kinds of studies that have tried to look at if you're using 2 strands and the number of weeks and the amount of newtons that can be generated, and you certainly generate more newtons, but whether that's translating out into a better result, I think is questionable. Now, so that's zones 1, 2, and 3, which are the more controversial, 1 and 2. But when you get to zones 3 and 4, which is much more in the trauma area, what do? So you get a forearm laceration where the brachial artery's out in the antecubital fossa, and you've got some cut muscle, and it's slashed distally and cut some tendons. Do you repair it? I think that the evidence is minimal that a hand surgeon adds very much at that level. That doesn't mean they don't. It just means that there's not a lot of evidence that they do. The tendons have a different size and a different shape, and I think doing a figure of 8 can get the job done. Now, that would be considered heresy by many hand surgeons, but I believe it. So once you start getting really up from the wrist, things change. When you repair someone in zone 3, I still think that can be problematic. They still have to be treated like a zone 2 in terms of placing the suture. In zone 4, they get stuck down postoperatively, but they loosen up much better than they do at zone 3 and zone 2. Okay, this is just the postoperative management. But if you're up in this area where the tendons flatten out and they meet musculotendinous junction, as long as you understand the anatomy, I think the repair is really pretty straightforward. Now, there was a study about the treatment in zone 3 to 4 by these authors. Wolf is well known. He's at the Hand Surgery Center in New York. And I think the seminal quote was, despite the frequent occurrence, there is a paucity of literature on the outcomes for flexor tendon injuries in zone 3 to 4. Now, I'm speaking from experience when I talk about zones 3 and 4 versus getting up into 5. I'd be cautious with 3 and 4, but I have to admit our data is poor. So your repairs are easier with better results as the numbers go down. It's pretty simple to remember. Complications. I think it's rare in almost any field that you can find seminal articles that have done data which seems to tell you something. I'm going to show you a paper now that I'm impressed by, but I have to tell you, I never fully accept being impressed until I had a statistician sit down with me to make sure that I understand the statistics. And when it comes to meta-analysis, I understand a lot less statistics than I do with Bayesian and frequency issues. So, because it's a different nature. So I haven't delved into the statistics on this, but there's a great article where they took 599 articles, they reduced it to the criteria that made it analyzable, or they could analyze it with a meta-analysis, and they came up with the following findings, which are worth remembering. So if you repair a tendon, the rupture in the forearm and in the hand, the rupture rate, and I have to back up. I'm pretty sure this was zones 1, 2, 3, and 4. I'm not sure if they included 5. The rupture rate is 4%, adhesions is 4%, reoperation rate is 6%. Rupture rate was not related to the suture technique. So you saw all those pictures? They couldn't prove that there was any relation to doing the Sugi versus the Savage made any difference. Now remember, because you can't find the difference doesn't mean they're the same. It's the type 2 error issue. Numbers are too small, which often happens to us. That's what struck me in the last lecture when you're trying to figure out, where do you start, where do you find the bleeding. We often, what we call the art of medicine is just lack of statistical analysis, and we have to make a guess. Use of techniques. Use of techniques, other modified Kessler had 134% increase of adhesions beside the Kessler. Age, gender, zone of injury, use of epitendinous suture, study quality, data publication were not predictive of forming scar tissue around the tendon. In other words, basically looking from 1970 till the 2005, nothing's changed. Once again, I think that would be heresy. Most hand surgeons probably wouldn't agree with that. The only thing they could say was that the modified Kessler repair with an epitendinous suture seemed to get the job done, which is just a simple box and then putting some running suture like a Lambert through the tendon. The epitendinous outside. And that's just what I told you. So, where are we? How? Flexor tendons, should we be using multiple strands at the core? I'm not convinced that it shows any difference. Where, immediate to the first couple of weeks, when and where, with less training, you do it more proximal, okay? If you've got a lot of training in the hand, go down into the hand. By whom? Whoever has the training. I mean, it's, this, to me, hand is a field that crosses orthopedics, general surgery, and plastics. And if you have the training, you should do it. Now let's move on to something that's even more confusing, and I'm going to skip through parts of it because I put too much in there, I think, and it's the end of the day. So let's try to get to the essence of nerve repair. Who should be doing nerve repair? Now this is going to get a little bit tricky. If you cannot use a microscope, you should not do extremity nerve repair. Now that's what I believe, but I can tell you, let me make one more statement. Using a 6-0 large suture for a nerve is an indication you don't know what you're doing. I see this all the time. The patients come in, their median nerve's repaired, and it's got a big 6-0. Now with that said, now when you quote me to your friends and they're mad at me for implying all of this, I want you to remember this. There is no evidence that microscope improves results, okay? So now we're down to the fetal monitor and standard of care argument. I think the biggest danger is not getting someone like me as your expert witness, if I'm testifying against you. So if you used a 6-0 on a median nerve and the guy got a poor result, I'd have to say there's no evidence at all that makes it any better or any worse. There have been 2 studies in the literature where they tried to look at loops, and they found no difference. Again, type 2 error. No difference doesn't mean that there's not a difference. I mean, it means they couldn't find the difference. It doesn't mean they're the same. You have not proven bioequivalence. So the fact of the matter is, you can repair a nerve with a 6-0. You can repair a nerve without a microscope. You probably, if there's a bad result, could find yourself in problems with standard of care argument that that's what hand surgeons are there to do. Get me as your expert witness because I'll tell them that there's no evidence in the literature makes any difference. When, this is another bad one. You can't sit on this forever. Nerves retract, and once they retract, you can't get primary repair, and if you can't get primary repair, then you have to nerve graft, and if you have to nerve graft, it is, again, accepted wisdom, and I'm not 100% sure we have the evidence to prove it, that the results are worse. You have 10 days, maybe 2 weeks, maybe 3 weeks, but you don't have a long time. I would say, get the patient on their way there in the first week, and this happens all the time. I see patients all the time. Unfortunately, and it's often, the trauma surgeon sees them, they say, go see your surgeon in a week, but then they got to go through insurance, the insurance doesn't understand, they delay them. So as a trauma surgeon, if you see this, what you need to tell them is, look, this is terribly important. Go to the office even if your insurance hasn't approved it because it'll get improved. They don't understand what's going on. Now, this is my own made-up statement. Nerve repair is nerve dependent. That seems obvious, but what I mean is repairing a median and ulnar radial nerve is not the same. Median normally gets better results than ulnar, and radial the worst. That said, I found an article right before when I always review articles before I do these talks to try to make sure I'm updated, and I found an article that claimed the opposite. So I'm a little bit of state of confusion. I certainly know that there's good evidence from Dillon and McKinnon that the median and ulnar nerve at the wrist, the ulnar gets better sensory and less motor, the median gets more motor and better and worse sensory. Now, I'm sure you all know there's a bunch of different ways of doing nerve repair. You can put the trunks together. You can put group fascicles, which means you actually break it down to all little strands, or you can put the groups of fascicles together. Once again, there's no evidence that it makes any difference. Whether you put a 6-0 in or whether you go in and put all the nerves together under the microscope, no difference. Nerve gap, you don't want to let a nerve gap happen. Now, if it's a gunshot wound, they blew it out, there's nothing you can do. But don't leave the patient sitting around. But if there is a nerve gap, the old method used to be joint position, bone shortening. I mean, if the humerus is blown out and you want to shorten it to put it together reasonably, that's okay. But to actually cut the humerus or cut forearm bones that used to be done to get nerves together, that's obviously unacceptable now. But rerouting and mobilization are the only techniques. And technically, you're not supposed to put a lot of tension on the nerve. If you can't hold it together with a microsurgery or two, you've got too much tension on the repair. Nerve grafting. Now here's where we could really get in trouble, and I think I'm just going to bring it to an end. I'll try to go through it quickly, but I'll get to the principles. I became a big nerve grafting kind of expert at one point and developed a whole teak, did all kinds of research for over 15 years. Bottom line, I could never prove that it made much of a difference. Very frustrating. I became kind of a world's expert, and I always wrote the textbook chapters, but it didn't make any difference. That's the definition of frustrating, or minimal difference. But you should know that, understand this, so just don't get caught out and look silly as a trauma surgeon. When you do a nerve graft, you're doing a living transplant, self-to-self, auto-transplant to Schwann cells. No Schwann cells, the graft doesn't work. If you lyophilize it, if you irradiate it, doesn't work. You have to have living Schwann cells. Did you all know that? I hope so. I mean, because I would have residents and fellows in hand surgery say, well, yeah, but it's just the conduits. You're just doing the conduits. No, you're transplanting Schwann cells, or auto-transplanting Schwann cells. Age, mechanism of injury, nerve injured, level of injury, time of injury, all play a role, and no one really understands. Obviously, younger is better than older. Less injury is better than more injury. Nerve injury has differences, but you'd rather be distal, close to the target, than proximal. And the timing of injury, just don't let it get out too far. Defect size, recipient bed, motor sensory identification. I think I'll stop there. My work was in blood flow to nerves. I spent a lot of time looking at the fact that nerves have an extrinsic blood flow. So if you look out here, they have an extrinsic blood flow, and then they have an intrinsic blood flow. And so I was able to show you could cut the intrinsic and keep the nerve alive on the extrinsic, and the reason that you did that was, let me just skip to it, so that you could fold a nerve and use it as a vascularized nerve graft. So we did a lot of work on vascularizing nerve grafts, and there's one great article out of Japan where they did a bunch of them showing some increase, but it's marginal. So I'll stop there and let me just summarize it. Be very careful, zones 1 through 3, even 4. The nature of the tendon requires a core suture. We know that you can make it simple and it will, it's going to work fine, but what you want to do is as you get more to zones, out of zone 4 and into zone 5, you'll be able to easily just use a simple figure of 8 suture. The other issue, so who should do it is just your training, where you do it, get out of those zones, when you do it, get within the 2 weeks. And in nerves, it's basically the same. You have a couple of weeks. If you have the training, do it. Most people don't have the training. I think you have to use a microscope for some of these repairs in order to make it effective. I want to thank you very much. And if you're ever having trouble with your nerves or your tendons, send them to me. Thank you very much.